and start.
Hello, good evening, everyone. I welcome you all to today's webinar of SPECT. And today's topic is very, very interesting. It's all about the latest kid on the block in our bone marrow transplant and cell therapy. That's gene therapy. That's what we are going to discuss today. We have a chairperson who is very renowned, Professor Tulika Seth from AIMS. She's one of the top consultants there in the hematology. So I'll request her to chair today's session and introduce the speaker. Over to Dr. Tulika Seth. Thank you.
Thank you so much. It's a pleasure to be here on this platform. This is a very important platform on transplant and many other important, innovative things that we have now available to us in hematology. And we're very fortunate to have Dr. Lakshmanan Krishnamurthy, who's Professor of Pediatrics, Section Chief Pediatric Hematology, Oncology, Bone Marrow Transplant at the Yale University School of Medicine, USA. He's a very important voice, both in the area of bone marrow transplant in sickle cell as well as in gene therapy. And as you all know, we now have several gene therapy approved for sickle cell as well as for thalassemia. And we're delighted to have a recorded talk by Dr. Krishnan Murthy to start off with, and hopefully he will join us later on. Thank you. I can't hear the voice.
Ria, the voice is not coming.
It's muted.
And the difference
Can you hear now,
between
sir?
Yes.
gene therapy and allogeneic bone marrow transplant. In autologous gene therapy, we use the patient's own stem cells as opposed to hematopoietic cells from an allogeneic donor. Patients get chemotherapy. The standard in gene therapy is 4 days of myeloablative dose of busulfan. The conditioning regimens for transplantation are a myriad. Could be myeloablative, reduced intensity, or non-myeloablative. The main difference is because there's no risk of graft versus host disease, there is no need for prolonged immunosuppression. This is not a trivial difference. Patients who have a gene therapy typically go home on prophylactic antivirals, anti-PJP, in oral antifungals, as opposed to multiple medications and other supportive care medications that go with them. In gene therapy, stem cells are being modified. Now, currently, most of these modifications are happening ex vivo, but in the near future, there will be in vivo modifications as well. As opposed to this, bone marrow transplant typically does not involve genetic modification of the stem cells. One can arguably say that the genetic modification introduces us an uncertainty which, compared to this, the natural hematopoietic stem cells may behave in a more predictable manner. There may be also long-term risks due to the genetic modification of target effects or due to a viral vector. Since there is no genetic modification and there is no viral vector, allogeneic transplant does not carry that risk. The long-term risks due to chemotherapy are, as you can imagine, similar in both of them. Let's start with sickle cell disease. This is the area where the progress has been quite dramatic. Why consider gene therapy for sickle cell disease? Well, I think the obvious reason is the severe impairment of the quality of life. And here, as you can see, that in patients with sickle cell disease, in pediatric population, sickle cell disease has a quality of life which is only slightly better than that of a patient with cancer on treatment. While in an adult patient, the quality of life is worse than that of a patient with cancer on treatment. I would like to walk you through what happens in the clinic and in the laboratory for a patient undergoing gene therapy. Once a patient is enrolled and considered appropriate for gene therapy and has appropriate organ function to have an autologous transplant, the process starts with autologous stem cell collection. At the beginning of gene therapy research in sickle cell disease, we had the dilemma on how to mobilize stem cells. At the time, while we knew that GCSF was contraindicated in sickle cell disease because of risk of very high white count and pain crisis and stroke, there was not a lot of experience with using plerixafor. Since then, plerixafor has become the standard of care for mobilizing patients with sickle cell disease. This is quite a process. Generally, patients get admitted on a Sunday, get a central line placed on Monday, get an exchange transfusion, and then Tuesday, Wednesday, Thursday, go on the stem cell collection floor for undergoing apheresis. That's partly because the target stem cell collection is so high, typically about 17.5 times 10 to the 6 per kilo body weight of CD34. Often patients require 2 to 4 collections. Most of the time in 2 collections, we're able to do that. From a patient perspective, this is not trivial, and one would not have anticipated that as a clinician until one had seen how much patients had to undergo through this. One important point here is the kind of access. Having thought and worked through a number of different access catheters, a short-term Quinton catheter is usually the best to work with the apheresis machine. The stem cells are then sent to a specialized laboratory. This is a rate-limiting factor, and as I anticipate over the next several months, as gene therapy takes off in a big way in the US, that manufacturing facility appointments are going to be a rate-limiting factor, and there is a lot of room for expanding capacity. In fact, stem cell collection is planned after the manufacturing slot has been secured. The genetic modifications are broadly gene addition or gene editing. There obviously are several variations on the theme, but I am limiting myself to the 2 that are FDA approved. And this is the gene addition of a non-cycling globin gene by using a lentiviral vector. As you can see, this is the lentiviral vector with the non-cycling beta globin gene. And the vector transfers the genetic material and then vanishes. There is no replication competent lentivirus in these patients. And this approach was pioneered by Bluebird Bio, and it now goes by the name Lyfgenia. The second approach is gene editing, is using CRISPR-Cas9 to recognize promoters responsible for the globin gene switching. And this gene editing by reactivating fetal hemoglobin is now approved by the FDA and is called Casgevy. Once this manufacturing process is completed, which takes about 4 months, then patients are brought in for an autologous transplant, get high-dose chemotherapy with busulfan with pharmacokinetic dosing. And after that, 3 days later, they receive the stem cells, typically stay in the hospital for 35 to 45 days, and then essentially are followed as an outpatient for side effects and for rehabilitation, especially of chronic pain. 95% of the patients are free of pain crisis. So this is the state of the art for gene therapy for sickle cell disease. You have two choices, Lyfgenia and Casgevy. This was the paper in 2022 of the Bluebird Bio study. In full disclosure, I'm an author on this paper and a participant in this clinical trial. This is a very exciting study for a few reasons. Number one, they were for the first time able to figure out how to get a substantial vector copy number, that is the number of copies of the vector per diploid genome. For the longest time, this had been the rate limiting step with vector copy numbers pretty close to 0.5. And as you can see, they were able to get some really high numbers. Now this may not always the best thing to do. Having a lot of extraneous DNA might have implications that we are not totally sure of at this point. The second thing that they showed was that after the transplant, there was a persistent expression of beta globin that was coded for by this laboratory-created non-cycling beta globin gene. And then as you can see that this goes up gradually in its expression for the first 6 months and remains stable over a period of time. The third major finding here was how it impacts the clinical expression of beta globin. As you can see in this picture, red is good, green is bad. And over time, patients developed about 50% non-sickle hemoglobin, 50 to 55% non-sickle hemoglobin. As you know, sickle cell trait is typically 60% non-sickle hemoglobin. So this would appear that this is close to sickle cell trait. Another major finding biologically was the fact that by 9 months, red cells were positive for BA-T87Q. So the distribution of non-sickling hemoglobin was likely pancellular rather than heterocellular. And that's how it may be different from blood transfusion, where by definition, the non-sickle hemoglobin is heterocellular. Again, this has been discussed quite a lot about hydroxyurea as well. So HbA-T87Q stabilized by 6 months and was present in a mean of 85% by 24 months. And the amount of AT87Q was about 15 picogram. And this per red cell, and in HbAs, it's 13 to 18 picogram is what the hemoglobin A is. So we believe that these data suggest that not only the genetically created hemoglobin pancellular, but it is an adequate quantity to inhibit sickling as it is similar to what one might expect in sickle cell trait. This cartoon shows that severe VOCs, which in this case were about 3.5 per year prior to gene therapy, was 0 post-gene therapy. It's quite a striking finding. 90% of evaluable participants experienced complete resolution. And those with evaluable health-related quality of life scores reported improvements in pain intensity, pain interference, and fatigue. Unfortunately, there were 2 cases of malignancy. We're not quite sure what happened, but this is the reason why the FDA gave a black box warning saying that these patients have to be followed for the long term. These were the 2 patients who developed leukemia. And then the first patient was a 42-year-old who was part of the early patients, had a very low vector copy number of 0.1. As you saw, we saw vector copy numbers of 2 to 5. And the AT87Q was not 50%, was only 11.9%. But somehow the patient did not have VOEs, though the patient had persistent hemolysis. And then 3 years post-treatment developed AML. Interestingly, the blasts were negative for the vector. There were multiple driver mutations that are typical of chemotherapy associated with AML, and unfortunately was fatal. The second patient was similar, had a very low vector copy number of 0.05, very low T87Q, continued to have pain, continued to have hemolysis, and 5.5 years later got leukemia. The blasts were vector positive, but the site of insertion, VAM4, which is involved in neurogenesis, has no role in AML. So it's not clear why this person got leukemia. There were multiple driver mutations, so this person is behaving as if they had chemotherapy before. Unfortunately, the complications were fatal. So at this point, we don't know why these 2 patients got leukemia. Is it related to a leukemic potential from the pressure on cell multiplication because of the cell turnover in sickle cell disease? The answer is not known. The other major approach to gene therapy for sickle cell disease is to reverse the fetal hemoglobin switch to adult hemoglobin. And the first target was BCL11A, which Dr. Shankaran described when he was still a medical student. Reversing this, targeting the suppression of BCL11A can result in increased fetal hemoglobin, which will inhibit sickling of HBS and alleviate manifestations of sickle cell disease. And this was reported earlier last year by Frangel et al. In the New England Journal. In their study, 44 patients with sickle cell who had received exa-cel, of them, 31 were evaluable, 93.5% did not have vaso-occlusive crises in the follow-up period. 95% were vaso-occlusive event-free at 12 months. There was 1 death due to COVID-19. As you can see, the mean VOC-free duration is 22.4 months. This was achieved in the 12-month VOC-free was achieved in 96.7%. This picture again shows what we had seen previously, that the likelihood of VOC was dramatically reduced in patients after transplantation. Another important factor to remember about gene therapy is how long the journey is. In January of 2024, patients that I started after they had been referred to me, they then had to have comprehensive evaluation, disease management, and starting on chronic blood transfusion, collection of stem cells, fertility preservation, and my first patient of the January 2024 group underwent gene therapy in January of 2025. I'll follow this patient once they leave the hospital for a total of 15 years. So gene therapy is not a quick solution. It takes a lot of time. It also gives a lot of time for the patient to prepare for the therapy. There are many patient issues in decision making. Eligibility criteria have inconsistencies. The FDA says gene therapy is approved for patients who have a history of VOC. Many others may have qualifiers that they may want to add about what history, how many episodes a year, inpatient, outpatient, how many years. About 3/4 of patients report being willing to take a modest risk of mortality and GVHD. This was Eric Kodish's paper from 1991. We don't know what kind of risk they would be willing to take for an autologous transplant, but certainly patients do understand that GVHD cannot be a good thing. Most patients who consider gene therapy do so because of an unacceptable disease burden, the repeated need to seek healthcare and a poor quality of life, the inability to pursue life goals, a recent episode of worsening of disease-related complications, the need to make a major therapeutic decision, or concerns about the long-term consequences of sickle cell disease. There are many pending issues about awareness, acceptance, access. Chronic pain syndrome does not necessarily go away. It's due to peripheral and central sensitization, could be related to avascular necrosis. There may be psychological comorbidities that may be related to and interact with sickle cell. Family issues, again, a big burden of care. We really need multidisciplinary intervention, which it should be, the hallmark of which should be consistency and repetition. My personal goal is for every patient by day 60 post-transplant to be pain and pain medicine free, to live a life to the fullest, free of pain meds, free of restrictions and limitations caused by sickle cell. Briefly, we'll touch on gene therapy for transfusion-dependent beta thalassemia. This is a paper that Alexis Thompson published. Again, there were dramatic improvements in changes in transfusion requirement after gene therapy. This was the gene addition by Bluebird Bio. Here are the outcomes in 22 patients. And as a result of this, Zynteglo, an autologous hematopoietic stem cell-based gene therapy for adult and pediatric patients with beta thalassemia who require regular blood cell transfusions, was approved. The FDA notes no contraindications, does counsel that antiretrovirals and hydroxyurea be held for a month prior to mobilization, to stop iron chelators 1 week before conditioning, and avoid myelosuppressive chelators for 6 months. Casgevy similarly has shown promising gene editing data. Out of 52 patients, 35 were evaluable at the time the data was reviewed. This was used in ages 12 to 35 in the clinical trial, and 91% became transfusion independent. And so Casgevy is FDA approved for patients 12 years and older who have transfusion-dependent beta thalassemia. Briefly touching on other conditions, here's gene therapy for adrenoleukodystrophy. I found this quite interesting because not only they had 32 patients, and they followed all of them for 24 months and have put them in a long-term follow-up study. At 24 months, none of these patients had major functional disabilities. Overall survival was 94%. Neurologic function score was stable compared to baseline. And then 81% of the patients had no major functional disabilities. Unfortunately, hematologic cancer developed in 7 of 67 patients after the treatment with this gene therapy. This raises a big question mark. It may be related to the particular construct, so stay tuned to learn more. Most recently, we have metachromatic leukodystrophy. Very interesting because they not only had 29 pre-symptomatic MLD patients, but they also had a 31 patients cohort in the untreated natural history cohort. And 26 patients were alive, 3 patients died as a result of disease progression. But the R cell level was actually really good, went up by 18-fold, over 18-fold in those with late infantile variant and 5.7-fold with the early juvenile variant. And patients did better than controls, and most developed a normal cognitive development with prevention or delay of central and peripheral demyelination, and this was FDA approved. I will summarize that transplantation of ex vivo modified autologous hematopoietic stem cell offers a potential for transformative amelioration of genetic disorders. Results of early and intermediate term follow-up are promising. Following the approval by regulatory authority, implementation in clinical settings is beginning. This is a very exciting time. Government insurance and third-party payers in the United States and different parts of Europe and the United Kingdom are beginning to pay for these expensive treatments. We will see how all of this pans out in the upcoming months and years. But there is no question that many unanswered questions in access, acceptability, affordability, assessment of outcomes, and adverse events. So please stay tuned. Thank you.
So thank you. That was a really brilliant talk. And I hand over to the organizers for the panel discussion. Thank you.
Hi, Sunil.
So hi, good afternoon, everyone, and thank you for logging for this very important session today. I think we had a very exhaustive and quite comprehensive talk on gene therapy for various conditions, focusing on hemoglobinopathies. I know it's a long way for us still to go, but we have made good strides and good progress in CAR T therapy, and I'm pretty sure that in the next years to come, we'll have our own indigenous work and our own indigenous product for gene therapy as well. And you must already are aware that there's something available only for hemophilia from our own country. So I have my friend Dr. Gaurav Kharia, who's going to be taking us through what is currently the landscape of gene therapy and gene editing in our country, and also progress which has been made, and also the baby steps we are taking in some of the disease conditions which were mentioned in the previous talk. I encourage all of you to please post your questions, and we'll be asking those questions to Dr. Gaurav and the expert panel, which is going to be participating in this discussion. So, Gaurav, thank you very much. And if you could introduce your panelist and start the discussion, please. Thank you.
Right. So thank you, Sunil. And this was a phenomenal talk by Dr. Lakshmanan. Just give me a second. Yeah. Unfortunately, Dr. Lakshmanan had a last-minute commitment, so he could not join the session basically. And he could not join the session, and that's why he sent this recorded. And he was also supposed to be a panelist, but he said that whatever questions are there, he'll be happy to answer them on mail. So that's why, as Sunil has said, please post your questions, and we'll direct them to Dr. Krish and have his opinion and pass it back to you. So after this important uh, session, we have equally interesting panel discussion on genome engineering success and challenges, and what baby steps have been taken, and where do we stand as a country. So what I'll be covering is I'll be covering through some of the basics of genome engineering, as I say, which comprises of both gene therapy, vector mediated gene therapy, and also the genome editing. So what are the tools available? What are the basics of gene therapy? Because that is very important for us to understand to move ahead. As far as the panelists are concerned, Dr. Krish has already, Dr. Tulika has already introduced him. So he's an eminent person and has done a lot of work in transplant as well as gene therapy for sickle cell disease. Then we have Dr. Subhashish. So Dr. Subhashish is the associate consultant in pediatric hemato-oncology, transplants, and cell and gene therapy at Apollo Hospital, Calcutta. And we have Dr. Vinod. Dr. Vinod is a consultant pediatric hemato-oncology and transplant at Koveri Hospital, Tirchi, Tamil Nadu. So we'll move on to the panel discussions. Vinod and Subhashish, both of you are there?
Yes, sir. Hi.
Okay. Hi,
Sir.
hi, hi.
Yes.
If you can just, if you can open your camera, that would be really good. Thank you. Right. So, as this lady, Barbara, who heads the research wing of Roche Pharma, she said that to advance science, we need to think about the impossible. And that's what we are doing in today's day and age as we explore or venture more into cell and gene therapy. Now, as highlighted by Sunil, this is something which is a moment of pride or a matter of pride for all of us as Indians, because this is the first successful gene therapy using the lentiviral vector for hemophilia, and which has successfully completed the phase 1 in human clinical trial. And this was published in an EGM in December 2024. The work was led by the CMC group. The PI was Dr. Alok Shrivastava and his entire team. So the salient features of this trial was that it is the first in-human phase 1 clinical trial using lentiviral vector as a delivery vehicle for hemophilia A transgene. Whatever work has been done previously and the FDA approval has been given in hemophilia A is using the AAV vector. So this was the first time LV vector was used, and it was found to be much more efficacious. So the levels of factor 8 levels were much better using this approach as compared to the AAV approach, which was used in the previous studies. The transgene and the LV was developed by Emory University, where Dr. Krish was also working earlier. Product was manufactured as CSCR, which is a DBT facility at CMC Vellore. I'm sure a number of you might be aware of this facility. And trials were done at CMC Vellore. So 5 patients were treated with this product, which is CD68 ETB3 LV transduced autologous cells. All 5 documented desired increment in factor 8 levels with no bleeding episodes till the last follow-up. So this was definitely a very sort of encouraging piece of work which has been done at CMC Vellore. And this is the first step which we have taken as a country in sort of gene therapy space. CAR T-cell space, we all know a lot of work has been done, and a lot is going to come in future. But as far as the gene therapy is concerned, this is the first thing which has happened in the country. Now, what is gene therapy? Subhashish, can you, in a very simple way, let us know what gene therapy is all about?
Yes, sir. So gene therapy is basically the way by which we introduce therapeutic or healthy genes into patient cells, those patients who are suffering from genetic disorders, and we use viral vectors. So by this way, we can introduce these therapeutic or healthy cells into the patient cells.
Yeah, so I mean, very appropriately put. So it is introduction of a therapeutic or healthy gene, or also the silencing of the defective gene into the patient's cells usually using a viral vector to treat genetic disorders. Now, these viral vectors can be different, as we'll see in the subsequent slides to come. So there is this therapeutic gene which is called as transgene. We have a viral vector. So this viral vector is used to carry this gene and introduce it into the human DNA and subsequently get the desired effect. Now, let us look at the commonly used gene therapy terminology, which is very important for us to understand this subject. Now, these are the commonly used gene therapy terminologies. So, viral vector. So, this is a bioengineered, genetically disabled viral particle devoid of the components responsible for pathogenic potential. LTR is a long terminal repeat. So when we have a sort of a transgene, there are long terminal repeats on both the sides of this transgene, which comprises of U3R and U5 regions. Especially this U3 region has a strong promoter and an enhancer effect. Then SIN, which is a self-inactivating vector. So these viral vectors, we want them to die on their own after they have done their job. So for that to happen, we need to make them self-inactivating. Then transgene is the gene of interest. Promoter, there is a promoter region which is close to the transgene region, and this helps in introducing the transgene into the human DNA. Enhancer is required. These are short segments of DNA, and they enhance the transcription capabilities of these viral particles. Then there is an insulator. So once you have put your transgene, the surrounding sort of DNA should not interfere with the functionality of transgene, and for that, this insulator is placed on both the sides of your transgene. Then when it comes to process, titers, transduction efficiency, insertion site, and vector copy, these are the important parameters which we should know as far as the titers are concerned. So these viral particles which are being currently used, they are sort of given as a package. So like the lentiviral, third generation lentiviral particles, they are introduced as a 4 plasmid model. So all the 4 GAG, POL, these 4 plasmids are introduced separately to do the desired effect, to penetrate the cell wall, to introduce into the sort of DNA. But the chances that these viral particles will come together and cause pathogenic effect is highly unlikely. Now, all these particles put together forms the titers of that virus per cell. Transduction efficacy is the percentage of cells that have been genetically modified by the vector. Insertion site is the site where you want to insert this viral transgene, and the vector copy is the number of transgene vector copies integrated per cell of interest. So these are very important terminologies when we talk about vector-based gene therapies. Now, what are the viral vectors? Can you briefly elaborate these viral vectors, Vinod?
Yes, sir. Firstly, I would like to thank SPCT for the opportunity and without wasting time. So, viral vectors, as we have discussed in the previous slide, we need some vehicle to carry the desired genes and insert into the human genome so that they start working and correct the genetic defect. So, in general, we choose virus as the transport vehicle because of their special properties, that they have the mechanism to transport the gene into the human cells and make it function. So, and we also modify it genetically so that they don't cause disease, they don't continue to multiply, and they don't cause any harm to the body. So, the genetically modified viruses with the desired gene being attached to it, and they transfer it to the human gene is actually the viral vector in short.
Right. So yes, very nicely summarized, Vinod. So viral vectors are tools designed to deliver genetic material into the cells. These viruses have evolved to develop, the viruses per se, they have evolved to develop specialized mechanism which transport their genome inside the cells they infect. Modified viruses are used as viral vectors or carriers in gene therapy, protecting the new gene from degradation while delivering it to the gene cassette in target cells. Viral vectors effectively press target cells. They pressurize, they force the target cells to accept and separate the new gene from the virus particles and transport it to the cell nucleus. For example, the target cells begin using the new gene to perform its function, which is the gene of interest, also called as transgene. Most of these essential genes in viral vectors are missing due to the genetic engineering which we do, which means viral vectors are often grown in culture and they are non-pathogenic. Now, there are several types of viral vectors that can be used to deliver nucleic acid into the genetic makeup of the cells. Now, there's retrovirus, which was used initially. Then there are lentivirus, adenovirus, and adeno-associated virus, each with its own advantage and disadvantage for specific applications. Now, when we talk about lentivirus, which is used more nowadays, so can you tell a bit more about lentiviral vectors, Vashish?
Yes, sir. So lenti, this name is derived from a Latin word which is lentus, which means slowly. So these viruses are basically viruses which can cause slowly progressive diseases. So basically, these viruses are one genus of the family called retroviruses. So retroviruses are those viruses which have their own RNAs and which can make DNAs out of their RNAs from by an enzyme called reverse transcriptase. And lentivirus can be of different kinds, as for example, human immunodeficiency virus, HIV, simian immunodeficiency virus, bovine immunodeficiency virus. All these are examples of lentiviruses. These lentiviruses are basically enveloped viruses, and the advantage of using these can infect non-dividing cells as well. Vis-a-vis retroviruses, though the character is almost similar, but retroviruses can only infect cells which are actively dividing.
Right.
We have different classes of lentiviruses or viral vectors, and obviously the safety has been one concern, but safety is increasing with each generation. The good thing about lentivirus is lentiviral vectors they can carry quite large amount of genetic material into the cell compared to other the viral vectors like adenovirus or adeno-associated virus. So, and the inflammatory potential is also really low in lentiviral vectors.
Yeah, very nicely summarized, Subhashish. So lentiviral vectors, which are more in use nowadays, and as Subhashish has already highlighted, that they have evolved over a period of time from first generation lentivirus to second generation, and now the current ones which are being used are third generation lentiviruses. So lentivirus is another form of retrovirus that can infect even the non-dividing cells, as Subhashish said. HIV is one of the best example of lentiviruses. Although retroviruses are still in use, considerable efforts have been devoted to develop efficient and safe HIV-derived lentiviral vectors due to their ability to even infect the non-dividing cells, which becomes very important in hematological diseases. Thus, three different generations of lentiviral vectors have been established so far, with safety and efficacy both increasing with each generation. Now, coming to some advantages and also the disadvantages of lentiviral vectors. So, Vinod, would you like to highlight some of the advantages and disadvantages of lentiviral vectors?
Yes, sir. Actually, as you have mentioned, like compared to other viruses, recently lentivirus has become the predominant vector because of the advantages that it can carry even larger transgenes, like more than 8 kb, and it is more efficient in transferring, and it can infect both dividing and non-dividing cells. And the immunogenicity is less, so that the more important catchy point. And it's quite stable, and the integration into the genome, human genome, is quite stable, and the transgene gets expressed well. However, coming to the limitations, there is always a potential to have generation of the replication potential of the viruses. And the other thing, the mutations, it make us like we are like playing with the genes, so it can cause insertional mutagenesis. So that can be one potential undesirable effect of all these viral transfers. Thank you.
Right. So again, very nicely summarized. So if we talk about advantages, the first one very big advantage is that they can their packaging capacities is quite a lot. So they can carry the transgene, which is more than 8 kb, The gene transfer is very efficient. They can infect, apart from the dividing, non-dividing cells also, low immunogenic potential, and it's a stable integration which continues to be there for quite a long time. And the disadvantages are this replication, as we have seen in the presentation of Dr. Lakshmanan, that in the Lypgenia trial there were 2 or 3 patients who developed acute myeloid leukemia. So there's risk of insertional mutagenesis as well. So these are the things, but as we are moving ahead, these challenges are being addressed, and those were more so complications related to sickle cell disease in that particular trial. But the similar effect was not observed in the thalassemia cohort. So it will be wrong to attribute it to the third generation lentiviral vectors which were used in that particular trial. Now, if I just take you through the evolution of these viruses, how they have evolved over a period of time, keeping in mind the safety and efficacy of the viruses. So the retroviral vectors were the first one which were used initially. Okay, so gamma retroviral vectors primarily for our primary immune deficiency gene therapy trials. So they had these LTRs on both the sides of transgene, which is the long terminal repeats. Okay, and as we know that the U3 has a strong promoter and enhancer effect. Now, the biggest disadvantage of these gamma retroviral vectors were that they had this potential of insertional mutagenesis. So, in the initial PID trials, KIT trials, if you will go through them, quite a number of patients developed acute myeloid leukemia or acute lymphoblastic leukemia subsequently. Okay, so that was a big challenge. And that's why the next change which was made in these viruses were to make them self-inactivating. And how were they made self-inactivating? By removing this region which is called as the LTR region. So this was removed, and this decreases their promoter and enhancer capability. So this reduce the chance of insertional mutagenesis. But again, the another big limitation of gamma retroviral vectors were that they were not capable of infecting the non-dividing cells. They were capable of infecting only the dividing cells. So this limited their efficacy, and thus lentiviral vector came in picture, because they have this ability to infect both the dividing and non-dividing cells, and also all the advantages have been highlighted by Vinod earlier. So that's why the current preferred viral vectors are third generation lentiviral vectors, which are being used for majority of the trials. And if you look at the summary of these viral vectors, so it started with gamma retroviral vector, the lentiviral vector, and then there are non-viral AAV and adeno. AAV and adeno have faced a lot of challenges for different reasons. The main work which has happened in using the AAV vectors is in hemophilia. And one gene therapy was approved also for using the AV vectors. But unfortunately, it did not show the desired level of increment of factor VIII as compared to the lentiviral vector, which was used in the trial done at CMC Vellore. And more so when we translate it to Indian setting, a lot of our patients have antibodies against adenoviruses, which further decreases the potential of AAV-mediated therapies. So for us, definitely, lentiviral vectors are the way to move ahead. Now, when we talk about the gene therapy, so one is an in vivo and another is an ex vivo approach. So can you briefly explain these two approaches, Subhashis? What do we do in vivo and what do we do in ex vivo approach?
Yes, sir. So first, I want to discuss about the ex vivo approach. So basically, what we do is we harvest patient stem cells. We take the therapeutic gene, we insert the therapeutic gene into a viral vector. The viral vector is also termed as delivery vehicle. And then we insert the therapeutic gene through the viral vector into the patient stem cells, and that happens outside the body. That's why ex vivo. And then we infuse the patient's stem cells into the patient after we give him a brief the myeloablative conditioning. So that is ex vivo cell-based delivery of therapeutic gene. Now, the in vivo therapeutic gene is more common in those conditions where it is not possible to take out the organ or take out a part of organ out of the body. I'll give you some examples. So basically what we do is we insert the therapeutic gene inside the delivery vehicle, which is a viral vector, possibly an adeno-associated virus, and we inject the adeno-associated virus directly into the patient. And inside the patient's own body, the therapeutic gene gets inserted into the patient's genome. So basically, if I can give some examples, like for Leber's amaurosis, optic amaurosis, like blindness. So gene therapy is available in that, where we can do in vivo gene therapy. As for example, in DMD, we do in vivo gene therapy. So in these cases, we can do in vivo gene therapy. So basically, the only difference is whether the patient's stem cells are whether the therapeutic genes are getting inserted into the patient's stem cells inside or outside the body.
Right. Yeah, so basically, as the name suggests, these are the two main differences between ex vivo and in vivo. So presently, for majority of hematological disorders, the ex vivo approach is being used, barring some like hemophilia. But for hemophilia also, as documented very nicely in the CMC trial, the ex vivo approach has shown better results as compared to the in vivo approach. But yes, the long-term goal for everyone involved in gene therapy is to have a in vivo sort of a solution for majority of these hematological diseases, that we just give the injection to the patient and without any sort of preparatory chemotherapy or maybe antibody-based therapy, which will not be as toxic as compared to the present busulfan or treosulfan based conditioning. So these are the two approaches which are being currently used, ex vivo and in vivo, when it comes to gene therapy. Now, what are the challenges with vector-mediated gene therapy, Vinod?
So I think first we should say is cost. I think it's still costly. Even Dr. Lakshman mentioned it's costly there. So I think far from reach maybe for us in daily practice. And again, selecting vector as discussed, each vector has its own plus minus. So I think the optimal vector maybe still is under trial. And as discussed before, the gene changes which happen, the mutagenicity, transformation into AML, clonal evolution, all those things need to be considered before, like maybe we'll need some more data about all these incidents of all these complications and how to get away with.
So yes, I completely agree with you that although lentiviral vector or vector-based approaches have been found to be quite efficacious, but there are some major challenges, which is we still don't know which is the optimal vector, whether it is AAV for hemophilia or it is LV for thalassemia or sickle cell disease, or even LV can be used for hemophilia. So these are the things which are still sort of we are learning as we move ahead. Risk of insertional mutagenesis, although it has come down quite significantly, but yes, the follow-up is very short in majority of these trials, and we know that this clonal evolution and insertional mutagenesis can manifest at a later date also. And the cost incurred in manufacturing the LV particles is huge. So infrastructural cost is huge, and the technical know-how is also very limited. So these are the major challenges with vector-based therapies. Now, this brings us to another very important or interesting modality of genome engineering, which is gene editing. So can you simplify what gene editing is, Subhashish?
So gene editing, sir, is basically a technique where we can modify or we can cause desirable mutation in a genome to achieve a therapeutic effect. So basically, gene therapy is all of can be everything, starting from addition, then disruption and generation of new mutations. So all of this have happen in thalassemia. Like we can correct the bad globin gene and we can change it. Like Dr. Lakshman has already given an example of BCL11A enhancer disruption in Cas-JV and also HPFH mutation insertion. So these are all the different types of gene editing.
Right. So, as rightly said by you, in a very simplistic way, if I put it, so gene editing is a technique wherein a desirable mutation, whether it's a deletion, you want to delete a mutation, you want to add a desirable gene, or you want to cause disruption, such as what is being currently done in the sickle cell and thalassemia study, that you disrupt BCL11A so that BCL11A doesn't do its work. So these are the various approaches which can be done, and this is done using to achieve a therapeutic effect using various genome editing tools. Now this brings us to the genome editing tools. So what are these? First of all, gene therapy offers potential to provide a therapeutic gene expression which is closest to the endogenous profile by inserting corrective sequences in situ. This has become clinically relevant due to the development of various site-specific nucleases, which are zinc finger nuclease, talins, and lately CRISPR. So what these site-specific nucleases do, they cause double-stranded breaks, and these double-stranded breaks can then subsequently they can help us to either cause knockout or sort of insert a DNA. Okay, and once this is done, there are two ways by which the gene correction happens. It can happen either by NHEJ, which is non-homologous end joining, or by HDR, homology directed repair. We'll see what are the challenges with either of these approaches. Now, the placement of DNA conserves many native regulatory motifs surrounding the gene. So these genome editing tools, these are very, very site specific. So you can precisely cut the desired portion of the genome. So if you have a particular defect at any site, so these can precisely, using the guide RNA, they can precisely cut at that particular site and cause either a knockout or a addition of a gene of interest. Now, these are three main genome editing tools which we have. So ZFN, TALENs, and CRISPR. Zinc finger nuclease, TALENs, and CRISPR. So out of these three, CRISPR definitely stands out for obvious reasons. So what are the reasons why CRISPR stands out when we compare it with ZFNs and TALENs? So first of all, the off-target efficacy is low to moderate. Ease of application is there. Ease of multiplexing is quite high, and ease of generating large-scale libraries is also there. So that is why CRISPR stands out as compared to ZFNs or TALENs, and more so when we use CRISPR, most of the repair happens using NHEJ in contrast to ZFNs, which uses the HDR mediated repair, which happens less often when it comes to autocorrection in the genome. Now, can you briefly tell Vinod how this CRISPR-Cas9, how it evolved and how does it work?
Actually, even for me, it's very difficult to understand the final parts, but I'll try to just breathe through. It's a clustered, as CRISPR is a complex word standing for clustered, regularly interspaced, short, palindromic repeats. It also has CRISPR-associated proteins, which we brief as CAS. And they actually, just like how we operate a keyboard, it can cut, copy, paste, delete everything. So that the desirable effect would be the gene gets disrupted, or the gene gets corrected, or the desired gene gets upregulated, or the desired gene gets downregulated. That's what I can understand.
Right. So I'll try and simplify this. So how this CRISPR was identified. So a scientist in roughly 1987 in China, in Japan, he was working on E. coli. Okay. And he was looking at the alkaline potential of the E. coli and trying to understand which particular part of the genome, E. coli genome, leads to this alkaline nature of the bacteria. Now, when he was looking at this, he saw quite a number of repeats in the DNA, which he was not able to figure out what could be the reason for the same. Now, subsequently, a number of other researchers also observed the same thing, and then they realized that each time E. coli is exposed to one of the bacteriophages, okay, so every time it is exposed to a bacteriophage, it cuts a segment of bacteriophage, genetic segment of bacteriophage, and incorporates it into its own DNA so that it develops a memory against that particular bacteriophage. And if that particular bacteriophage infects that E. coli next time, it can act against it. So this is how after each exposure that genetic content from the bacteriophage is sort of taken out and incorporated in equalized DNA. So this is how the CRISPR sort of evolved, and using this capability of E. coli, this CRISPR-Cas9 system has been developed. Or is it clear?
Yes, very clear.
Now, how does it work? So these are precise site-specific nucleases. Now, how to guide these tools to a particular site? So you need guide RNAs. Okay, so suppose BCL11A, for example, is a big locus. Okay, and if you want to target a specific locus in BCL11A, you need to design your guide RNAs. So when you tag your guide RNAs to this CRISPR-Cas9 system, these guide RNAs take this particular complex to that part of the DNA where it attaches, the guide RNA attaches to that particular part of DNA, and subsequently the CRISPR-Cas9 system causes a double-stranded break. Now, when the double-stranded break happens, there is a capability of the genome to auto-correct the defect. Okay. Now, what are the things which can happen? Either the gene disruption can happen, as was mentioned by Dr. Krish and also highlighted by Subhashish. So this is the approach which is being used in hemoglobinopathies, that we disrupt the BCL11A. We do not let the BCL11A to move ahead, and this is how we cause induction of fetal hemoglobin. It is also used in some of the immuno-oncologic disease and DMD when it comes to gene correction. Okay, so when we have to achieve gene correction, here the repair happens using NHEJ, whereas when it comes to correction, it is a homology-directed repair in diseases like SCAD or hemophilia or Hurler syndrome. And this gene regulation to upregulate or downregulate gene, this is something which is sort of a very futuristic approach, but people are working currently with either gene disruption or gene correction. Now, as I said earlier, so once the double-stranded break happens, there are two ways by which the DNA can correct itself. One is NHEJ, which is non-homologous end joining, or other is a homology-directed repair. Now, chances of NHEJ-based repair is much, much more, okay, as compared to the homology-directed repair. But these are very precise as in contrast to NHEJ. So NHEJ is a better modality where you want to cause just the gene disruption. But when we talk about diseases where we want a precise cut to happen or to insert a gene, then you want a HDR, homology directed repair. Okay, so if I ask you, Subhashish, what are the challenges of these current gene therapy approaches at this point of time?
So, the first challenge I would say is the out of site and non-target site integration in the genome. Like the famous incident happened where SCID and ADA patients, ADA children were taken for gene therapy, and 5 of them have developed leukemia after the gene therapy. As Dr. Lakshman has also mentioned that 2 of his patients had got AML. And there is another famous case in which OTC deficiency, and this boy underwent adenovirus in vivo gene therapy and had a severe hepatic dysfunction, and eventually died after 4 days. So these are these unforeseen complications which may happen after gene therapy. And the second thing is what Sir has already mentioned is what I understood after reading a little bit, that basically when there is a disruption in the DNA, there can be 2 ways of repair. One is non-homologous end joining, which happens when the cell is not active, and another is homology directed repair, which happens when the cell is active in the cell cycle. So as Sir has mentioned, that the cell in most of the time is not active. So even if we want the cell to have a homology directed repair or homologous recombination, which will integrate the therapeutic gene into the genome, it doesn't happen. Rather, non-homologous end joining happens by the ligase, and the genome is not integrated, and on target percentage is quite low. So I guess these are the 2 problems, complications that may happen in the gene therapy nowadays.
Absolutely. So yeah, these are the challenges which people are still trying to address. Now, after looking at very important aspects of both vector-based gene therapy and also CRISPR-Cas9-based genome editing, Subhashish has a first-hand experience of treating one patient with gene therapy when he was working at St. Mary's, London. So, Subhashish, may I request you to take us through this case? It is definitely a learning experience, and as Lakshmanan highlighted, gene therapy is not a easy thing to do. So it comes with its own set of challenges, which we'll see in the case which Subhashish will take us through.
Thank you, sir, for giving me this opportunity. I'll go very briefly. This was a 7 years old boy from Egypt who came to us for gene therapy. And it was basically under CTX001 phase 3 trial. And he was a known child with transfusion-dependent thalassemia with transfusion which have started from 6 months of age and has received more than 150 mils per kg per year of red cell transfusion. And he was taken up for CRISPR gene editing of BCL11A erythroid enhancer. Next slide, please. So the criteria, inclusion and exclusion criteria of this trial was the age limit, which was earlier 12 years. It was much lower age. 2 to 11 years of age children were incorporated in this trial, but they have to be documented to have homozygous beta thalassemia or heterozygous beta thalassemia. The blood requirement should be more than 100 mils per kg per year of packed red cells. But if the diagnosis was less than 24 months before, then these children should be transfused every 3 to 4 weeks to be eligible to be taken into the study. The exclusion criteria was whether matched sibling donor or matched unrelated donor 10 by 10 HLA matched donors were present. Prior allo HSCT and alpha thalassemia children were excluded. Sickle beta thal children were also excluded. Those children who had an active infection were excluded, and also those children who had a cytopenias due to hypersplenism were excluded from this study. So after this child was taken up, we did apheresis twice for this child, and we actually kept aside 7 million cells for backup. And we sent more than 20 million cells, 334 cells per kg for the product. Though for sickle cell disease, there is no recommendation for GCSF mobilized stem cells, but for thalassemia, GCSF and Predixer for mobilized autologous stem cells were used. And CASJV recommends that we should send at least 20 millions of CD34 cells for product manufacture and 2 million cells to be kept for reserve. And backup cells obviously need to be cryopreserved before we start him on myeloablative conditioning. So these are the prerequisites, and that GCSF is not used, as I've mentioned, for sickle cell disease. Hydroxyurea and other medications for sickle cell were to be discontinued eight weeks before the start of mobilization and conditioning, whereas iron chelators, so iron chelators should be discontinued at least 7 days prior, which do not have any myelosuppressive effect. So,
right. So the course of this particular child, yes.
So this child was taken for transplant gene therapy, and from day -6 to day -3 has received busulfan with pharmacokinetics monitoring. IV busulfan was given, and even after the busulfan was finished, and from day +1, this child started to have mucositis. Then had recurrent episodes of cytopenias managed with IV antibiotics, and GCSF was initiated from day 22 because this child has engrafted his neutrophils on day +26. However, even after recovery of neutrophils, the problems didn't end. This child had multiple other issues, starting from progressive VOD, which is probably attributable to the busulfan which was given. And this child was started on furosemide and defibrotide infusion, but eventually the VOD subsided after 4 weeks. also had AKI, possibly attributed to the Lasix infusion, fluid restriction, and VOD, which has progressed to hepatorenal syndrome. Also had ARDS grade 4, and which required mechanical ventilation, and had TMA, which was managed with eculizumab. Due to mass, which was managed with steroids and tocilizumab, and all of these suppressant drugs had caused multiple viral reactivations, including adenoviral reactivation and multiple bacterial sepsis. And ultimately, this child had expired with sepsis and multi-organ dysfunction on day plus 22 of his gene therapy.
So the point of highlighting the things is there that if we feel that gene therapy is something which will be easy to deliver, is not the case. It comes with its own set of challenges which are not very different from the transplant scenario. And this child was a 7-year-old, so it was like class 1 or class 2 thalassemic. So very less chances ideally should have very less chances of having a sinusoidal obstruction syndrome. But I think people are trying to address these issues. Here, the key driver as I can see is this sinusoidal obstruction syndrome, which actually led to the onset of endothelial complications one after other, whether it was AKI or it was TMA. So if this could have been prevented, I think the course of this child would have been different. And this can be prevented if we move away from busulfan-based conditioning to treosulfan-based conditioning, what has been done in the CMC Vellore trial. So they have used treosulfan, and they did not see, even the patients were adult, but they did not see VOD in any of these patients. So I think that will make a significant difference if we move from busulfan to treosulfan, and that's what people are trying to do in majority of these gene therapy trials now. Now, coming to where do we stand as a country, because this was a discussion, but unfortunately, this is a very small thing to cover, because as Sunil also highlighted in the beginning, that we are just taking some baby steps. But just to summarize, two main things in any of the gene therapy trials is, one is your lentiviral vector manufacturing capabilities. If you're using the vector approach, lentiviral vector approach, or the CRISPR-Cas9 based genome editing. So these are the two main things. If you have hold on these two things, then your gene therapy trials or work can sail through without much of challenges. Now, presently, whatever LV vector we are getting, presently GMP grade LV vector is imported by majority of people who are working on gene therapy approaches. We all know ImmunoAct, they are using their own LV vector. They are manufacturing it on their own, but the cell bank for which they have received from NIH, US. Cellogen is making LV for its own use. We are also making LV for our own use for the CAR T cells. And subsequently, because it's a very important thing in majority of the trials, whether it is CAR T cell or whether it is gene therapy, if it can be provided locally, it will be of great help. So we intend to bulk manufacture LV once we are able to initiate or move through the clinical trials. Then when it comes to CRISPR-Cas9, so again, the majority of people working with CRISPR approach are importing it. However, IGIB has developed its own FN-Cas9, which they are currently using for their preclinical work for genome editing in thalassemia and sickle cell disease. And subsequently, they intend to use the same for the inhuman trials, and we'll have to see how it is working. Now, this is the overall landscape of gene therapy, primarily for thalassemia and sickle cell disease. I haven't covered for other disease like MLD or ALD, which are again it was done primarily at Bluebird Bio, and the trials had to stop because of the 7 patients out of 67 developing AML. But when we talk about the landscape for thalassemia and sickle cell disease, so these are the main companies. Bluebird Bio, it has 2 products both for thalassemia and sickle cell disease. Then CRISPR-Cas9, Casgevy, already been highlighted by Krish, and there are some other groups working like Sangamo. They're using a zinc finger nuclease approach. They are into phase 2. And then Editas is working with the Cas12. The trial which they are currently doing is Ruby trial. They published their data, very encouraging data in ASH this year, and they intend to finish their phase 2 clinical trial in second or third quarter of this year, and subsequently intend to commercialize it. When we come to India, these are groups which are primarily working. So we know IGIB InStem has done a lot of work, and Celogen is doing some work when it comes to genome editing or gene therapy solutions, primarily for thalassemia and sickle cell disease. Now, what are the other diseases for which gene therapy is an alternative or interesting sort of alternative, Vinod? Vinod, are you there?
Sorry, I forgot to unmute. So I'm here. So actually, basically, I think it should be applicable for all diseases with point mutation being the basis. So as we have discussed in the slides, severe combined immunodeficiency, viscotalrich CGD, MLD, ALD, sickle thalassemia, or these are all the diseases in line where who are likely to benefit from the gene therapy.
Sure. So I think that's very nicely said. So these are the diseases with point mutations. It has been successfully used for viscotalric syndrome, CGD, Fanconi. Beautiful work is happening at Stanford, led by Dr. Rajni Agarwal, where they're using antibody-based conditioning and subsequently using antibody-based conditioning for the gene therapy for Fanconi anemia. SCID, a lot of positive and encouraging work has happened. MLD, ALD. So as we have seen that Bluebird Bio studies met with some challenges, but I think they will try to address it and come up with something better to address those challenges. And hemophilia using AAV, this is FDA approved, but I think this will eventually be taken over by the LV-based approaches for hemophilia. So these are some of the gene therapy which has been FDA approved. So gene therapy for hemophilia A, again gene therapy for Duchenne's muscular dystrophy, gene therapy for metachromatic leukodystrophy, gene therapy for SCID, and many more disease for which gene therapy will be a promising option in next 2 to 3 years. So to summarize, genome engineering is an upcoming and promising modality to treat various genetic ailments. FDA approval for different diseases has been received. The most relevant ones are gene therapy for thalassemia and sickle cell disease, as we have seen in today's presentation. India has marked its presence in gene therapy by doing successful in-human clinical trial. First trial showing the efficacy of LV-based gene correction in hemophilia A. We need to strengthen our vector making capabilities because that's the crux for any gene therapy solution to be cost effective. Okay, if we have to import a vector, LV vector at the cost of 8 to 10 lakhs, that just defeats the purpose of gene therapy. So until we develop our own manufacturing capabilities, bring down the cost of LV vector to 50,000 to 1 lakh to 1.5 lakh, we will not be able to deliver a cost effective gene therapy alternative. The future looks very bright, and I'm sure in very near future we shall have our own indigenous, affordable, accessible, and safe gene therapy for thalassemia and sickle cell disease to start with, and subsequently for other diseases as well. So with this, I would like to thank you for very patient listening. It was a very nicely summarized session by Dr. Krish. And thank you, Vinod and Subhashish for the panel discussion.
Thank you, sir.
Over to Sunil.
So thank you, Gaurav. I think Gaurav, Subhashish, and Vinod, I think we had a very comprehensive masterclass on gene therapy. And I think I learned a lot, and some of the basics which were also covered were quite useful. There are a few questions. One, I would, Dr. Shrisha has asked a question about bleeding diastasis post gene therapy, especially when used gene editing, and risk of HIV infection post gene therapy. So this is some of the questions which Dr. Shirish has asked. There are a few more. I will take them once you go through this first one.
Yeah, so risk of bleeding diathesis, I think post gene therapy, there is no specific reason for this, but as you have seen in the case presented by Subhashish, I mean, there are a number of endothelial complications which can happen, which in turn can manifest as sort of bleeding episodes. I mean, hepatorenal syndrome per se becomes a very important factor to increase the risk of bleeding. So if you look from that point of view, that can happen. But per se, gene therapy related increased risk of bleeding diathesis, I don't think there is any increased risk. Either with the vector-based gene therapy or with CRISPR-Cas9-based genome editing.
HIV infection is another question.
again, the risk of HIV infection is not there now. I mean, it was there in the initial skit trials, but subsequently, as we have highlighted, the lentiviral vectors which are being used currently, they are very safe. They are self-inactivating lentiviral vectors, so the chances of having HIV infection is almost negligible nowadays with third generation LVs.
And Dr. Rajas asked a question: what is the expected delivery of gene therapy in India for thalassemia?
Right. So I
Billion.
think the push is quite a lot and this push directly comes from PMO. So there was a PM stack meeting on 21st of this month, directly supervised by principal scientific advisor. And government has committed huge amount of money, so almost close to $1 billion to be spent in next 5 years to take the cell and gene therapy work forward. So I think with that mindset from government and also the enthusiasm from researchers and also the clinicians, I think it will happen very soon, Dr. Rajat. Let's be optimistic and keep the timeline as next 2 to 3 years.
Yeah, it's going to be a few years, Rajat. I think most of the groups are on the preclinical state at the moment, so I think we don't have a phase one also that close yet. The other question, I think Subhashish can take it because he was mentioning about it, and that was what criteria for selecting in vivo or ex vivo method or vice versa.
Sir, I think in vivo are for those diseases which cannot be taken. I mean, stem cells, bone marrow problem, bone marrow stem cells, we take it out of the body and do the genetic engineering outside and put it inside. So I think for bone marrow diseases, hematopoietic disorders, we can select ex vivo genetic therapy over in vivo genetic therapy. But other diseases like MLD and other things, we can choose in vivo.
Yeah, that's, I think, yeah, correct. Summarizes it is hematopoietic stem cells mediated or correctable conditions, you lose ex vivo. Of course, as Gaurav mentions, there would be an interest and attempt to that also to in vivo, but at this point of time, that's ex vivo, and others are in vivo. Vinod, would you check antibody titers against viruses before selecting a viral vector to be useful?
I think I can understand that lentivirus has been chosen as the vector because it's less immunogenic. I think then the body cannot develop antibodies against these viruses. Maybe that's why it's being selected. So then I think antibody titers might not be a criteria to select which vector can be used.
But it does, that his question is quite valid actually. And Dr. Pavitra has asked this question, and I think one of the reasons where adenoviral vectors induce a strong inflammatory response is because they can be naturally, natural infections also with adenoviruses. And if there is a, shared epitopes and you have either cell or antibody mediated memory against those, you can generate an inflammatory response. And that has been one of the biggest challenges of some of these in vivo, cell therapies, gene therapies, where these vectors were used. And one of the advantages of lentivirus, which I think the CMC Velo group also has used, is this, that it doesn't have, it's not a naturally infected virus, and you don't have cell or humoral antibody responses to these vectors. Gaurav, one more question is there, is that if you have a viral infection during the course of gene therapy, and of course, you may have to give an antiviral. Is there any problem with that
Yeah,
when you use the gene therapy?
I think I
Viral?
was asked this question. Yeah, I was just asked this question by one of our staff nurses as well today. So I think these are like self-inactivating viruses, Pavitra. So once the viral vector is used for the introduction of transgene, subsequently they self-inactivate. So the virus doesn't stay when you actually infuse the product. Okay. So, as the need arises, whether it is adenoviral infection or XYZ, any CMV infection or any other infection, you can use antiviral drug as per the requirement. Okay, so it will not interfere with your gene therapy.
All right, so that's pretty much it, and I think we can close this session now. And I just wanted to make an announcement that is the next month session we won't be holding on 25th because it is very close to our annual SPCCT meeting, which is going to be held in Delhi on 1st and 2nd of March. So we will see you all on 1st and 2nd of March for a very interesting 2 days conference on transplants and cell therapy. And I urge all of you to register, attend, and participate. We had a huge interest in papers, and we received more than 50 abstracts for this conference already. And I think it's going to be quite interesting to discuss some of these issues in great detail during this conference. We have a galaxy of very reputed stalwarts in the field who are going to be talking on some of these very relevant upcoming topics in cell and gene therapy and as well as transplant. So with that, have a good night, everyone, and see you in Delhi on 1st and 2nd of March. Thank you very much. God bless.
So to conclude, thank you,
Good night.
MCure, as usual, for supporting the session. And we'll be looking forward to see you all in Delhi for the SPEC meeting. Thank you. Have a great night.
Thank you very much. Bye-bye.
Thank you, sir. Bye.